When you have an old patient walking in through your clinic and basically you have assessed that patient and you know that he's suffering from some sort of a geriatric ailment or some sort of a psychiatric ailment that is quite prevalent in that age group. We have discussed multiple ailments that are quite common, ranging from depression, it can be the mood disorders, obsessive-compulsive disorders, it can be the sleep disorders or the eating disorders, it can be the personality traits of that individuals that are emphasized in the older age groups, being schizotypical or being schizophrenoid in these age groups. So it can be the very late onset schizophrenia. So all of these terminologies that we've already discussed in detail in the relevant sections regarding the geriatric psychiatry, one should know what are the baseline investigations that has to be carried out when you're dealing a patient of psychiatric illness and he's in an age group that is basically almost more than 65 years of age. The assessment of that individual, how do you basically go about and take the history of that individual. Sometimes it's very difficult for these individuals to recall events in their life. So it's very important to take the collateral history from any individual who is basically performing the duties of a primary caregiver in the life of that person. So having the collateral history and having done with a detailed history from the person himself or herself, and once you have documented the history, it's very important to grade the disease. Grading the disease from mild, moderate to the severe form of disease is again very important. There are multiple methods for this. There are different questionnaires ranging from different varieties out there, and they're clinically resorted to when you're basically grading the patient while you're working as a psychiatrist. So the geriatric assessment, these are the baselines for the geriatric assessment. It's basically including the mental state examination in these individuals. And then we have the geriatric depression scale, which is also known as the GDS-15. It's known as GDS-15 because it basically contains 15 very important questions, significant questions that can basically make the evaluation more easier for the clinician. So the drug interactions, because these people belonging to this older age group, they are using multiple prescriptions alongside. So it's again very important to consider these drug interactions and know about them in detail as well over here. So we'll be discussing all of them over here regarding the mental state examination that we were already focusing on. It's basically abbreviated as MSE, and the patient's appearance, food stain, or the dirty clothes. So it's basically pointing out towards the factor of neglect. If a person is basically neglected in this age group, he's going to have that physical appearance of emaciation that is quite commonly seen in these individuals. And then we have these spectacles or hearing aid that is basically pointing towards the causative factors for depression. It was basically one of the major risk factors for the development of depression and anxiety in these individuals. Then we have the mobility problems. So due to the disabilities or due to the psychiatric ailments that are leading to the disabilities, these people can basically become immobile, and this has to be assessed while you're taking down that mental state examination in these individuals. Signs indicating the physical problems, for example, it can contribute towards the Parkinson's disease if he's having tremors. Cognitive problems, thinking, thought form, thought content has to be documented as well. Then we have the assessment of the psychotic symptoms alongside when you're taking about this mental state examination in these individuals. The psychotic symptoms can relate to the obsessive-compulsive disorders, the schizotypal personality disorders, and then it can be the very late onset schizophrenias that can even manifest over here. And you have to note down if you see any antisocial signs that are quite evident and that are quite prescriptive of the schizophrenia over here. So the risk assessment, all of the risk factors that are basically the late life stressors, if they are present in the life of the individual, they have to be highlighted as well while you're taking down the history. When we talk about the geriatric depression scale, choose the best answer for how you have felt over the past week. It's the question that you're going to put forth foremostly. And then you're going to go about like, are you basically satisfied with your life? So it's again going to contribute towards the thought form and the thought content of that individual. Whether he's satisfied from his life or not, that is going to basically highlight those factors. Have you dropped many of your activities of interest? So it's again very important to emphasize this factor as well. Whether he or she is suffering from anergia or not. All of these are very important. Do you feel like life is empty, life is finished, there is no purpose for life? All of these are the important or the significant factors to be discussed as well. Do you often get bored? So it's again one of the questions. If they do not feel pleasure in the activities which were found pleasurable previously, this can be one of the causative factors for the depression as well. Are you in good spirits all the time? So are you full of energy? Do you want to live, and what are the future plans? These are the questions that can be put forth. Are you afraid that something bad is going to happen? So an anxious individual would reply in a positive notion. Do you feel happy most of the time? It's again showing the emotions of that person. And do you feel helpless about your surroundings? Do you prefer to stay at home rather than going out and doing new things? So this is basically highlighting the antisocial behavior of that individual, which is making the person go into a depressive episode. So these are the highlights that have to be discussed with the patient. Then, do you feel you have problems with the memory than most? Do you think it is wonderful to be alive now? So, being thankful and being shown the positive aspects of the life is again one of the counseling factor. Do you feel pretty worthless the way you are now? And do you feel full of energy pointing towards anergia? Do you feel your situation is hopeless? Do you think that most people are better than you are? So the comparative study is again very important over here. How the person compares his or her life with the others. Is it in a positive way, or the view is pessimistic? All of this will be documented in detail when you're writing down about this geriatric depression scale in these individuals. Then if we move on to the pharmacological considerations, the amount of water and the muscle reduces and the fat increases. And then we have the water-soluble drugs such as lithium and alcohol. These contents should be evaluated as well over here. The smaller volume of distribution and the high serum levels. So one should know about these drug interactions. That is going to affect the dosages of the drugs that have to be prescribed for a normal individual and for an individual who is in a geriatric age group. So for the lipophilic drug elimination, the half-life increases in these individuals. And talking about the reduced renal excretion is again very important. For example, the reduced renal excretion is quite commonly seen in the lithium. Decreased hepatic functions and hepatic blood flow can be one of the causative factors. Decreased neurons and neurotransmitters, on the other hand, can be one of the risk factors over here. Starting doses and effective therapeutic doses are quite different in the people who are belonging to the geriatric age group. So basically here we discussed the normal considerations of the evaluation of a patient who is suffering from a psychiatric illness and he's belonging to the geriatric age group. So that is the end of this section. Thank you for watching sqadia.com.